Welcome to the Davies Use Case webinar being presented by Hospital for Special Surgery on census reporting and clinical pathway management. This is a Davies award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety here at HIMSS. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers for today's webinar. Don Williams, who's the Manager of Patient Access Services, and David Revin, who's the Director of Operational Excellence. Don and David, I'll turn the presentation over to you. Thank you.
Hello, my name is Dawn Williams, Manager for the Patient Access Services Department. I will share with you some information on reduction of work effort for our census notification. Now, Patient Access Services is tasked with bed management for in excess of 18,500 orthopedic inpatient surgeries yearly. This process requires us to closely monitor our bed utilization for immediate accommodation of our patients' volume. A hospital bed census is communicated to our leadership and our operational owners 4 times daily. Now, this is to proactively manage our bed capacity. This process was a manual and very cumbersome process. It involved us printing approximately 24 pages every morning at 6 a.m. This was our hospital census. This information was then used later in the day to determine patients that are going to be confirmed discharges and those who are pending discharges. We depended on calling the nurses on the unit as often as possible, disrupting their process to clarify information based on whether patients were being discharged or whether they were simply pending discharge. The system we used involved a time factor. Patients with a time entered in of 8 a.m. to 10 p.m. were considered confirmed discharges, and patients with a time entered of 11:59 p.m. were considered pending discharges. These were patients who were actually either waiting for a bed in a rehab facility or waiting to be cleared their PT. This information is then calculated, and of course, based on the subjective estimates, the census report was sent out. This report was sent 4 times daily, and it took us approximately 45 minutes to 1 hour to complete this process. Based on the complexity of the process, there were only few employees who were trained in completing this task. This, of course, caused minimal staffing flexibility. After the implementation of our EHR, we were very anxious to adopt a more efficient process. Thus, our operational leadership and IT sought potential solutions. Some of the challenges we encountered with the prior process involved inadequate reporting tools. We could not monitor our wait times. We could not track patient throughput. There were issues related to billing. Patients were dissatisfied there were instances where patients were charged. You would receive a bill for a private room, and the patient actually did not request that private room. They may have been placed there as house convenience. But this is mainly because any notes entered in the system were lost after patients were discharged. There was limited visibility of the patient's admission details. There were times when the bed planner had to access another system to be able to have access information on the patient. Now, this platform was not necessarily user-friendly. It took us approximately 6 clicks to complete patient assignment to a unit. There was inability to use indicators or communicate updates to other users, thus the telephone was used, disrupting the clinical team and their process. The information that was being disseminated was never done in real time, so the information was usually an hour later after it was disseminated. The census notification process was very important because of the various stakeholders involved. Continuous care services needed this information to determine whether an urgent admit or a transfer patient can be accepted into the institution based on the bed availability. Ambassador services needed this information to be able to verify whether patients will be receiving the private room that they needed, or whether their relative who may be staying over with them would have to book accommodation elsewhere. So this information was really important for us to be able to continue our process throughout the day. We had various goals and objectives of what we wanted. We knew what we wanted, but we needed to be able to discuss with our team what we wanted to have developed. It was important for us to be able to have an at-a-glance view of the entire hospital. Senior administration ever so often needed to know what our census capacity was. And after that call, the information that was sent to them was usually sent about 30 to 40 minutes later, which meant so many things would have changed during the time that information was being compiled. So the information was never necessarily accurate. We wanted a tool that would help us to reduce our PACU overnight volume. We wanted to be able to have CCS look at whatever the system we had could offer and be able to determine for themselves that we do have capacity and we can actually accept our urgent admits. We wanted a tool that would be automated. We wanted to be able to have the census be sent out and know that the information that was being disseminated was actually accurate information. It was in real time. We also wanted to be able to develop a better suited scale to train. We wanted to expand our training so that we'll have a higher number of persons who were capable of monitoring this process. We then utilized the PDCA method of continual improvement of the process. So our operational owners, the vendor, our IT team, we all met and included our front-end users along with our end users because they're the ones who are always in the system and they're the ones who are mostly affected. So with this, we sat down and had discussions, and we were able to, most importantly, scrutinize the data points to understand what aspects of the system we could automate and what we could not, because we were able to let them know what it is we actually wanted. The vendor made a proposal, and they aided IT in the build, the first build. This build was then shared with our stakeholders. We needed to have their feedback for them to understand that what we needed would actually work for the hospital. With their buy-in and their feedback, this information was then sent back to the team. We then decided to monitor the process. The dashboard was then built, and the monitoring ensued. This process took approximately 3 months. After the refined bill, the monitoring ceased, and we were able to move forward. In the monitoring or validation process, we compared the information from the database projection with the information that the bed planner compiled, and we will then look at this information daily and investigate any of the variances that we noticed. And this process continued until we got to the point where we were comfortable with the information. The outcome of all of this hard work was the HSS Capacity Management Dashboard. This dashboard is not only unique to HSS, it's unique to EPIC. No one had ever requested this information to be real time. This information was going to be used by patient access, by hospital for special surgery on a twofold basis. We needed our senior administration to be able to access this information at a glance. And as the dashboard shows, at a glance, they can be able to determine what our opening census was, what our projected census was, how many patients are expected to be coming in today. But we wanted more than that. We wanted our bed planners to be able to access information to send a report out 4 times a day. That will not take them 45 minutes to 1 hour, and would be so simple that anyone will be able to participate in this process. This dashboard is still a work in progress. We currently have added the bed board messaging board, which is at the top of the screen. Now, this is used for a reporting aspect for the bed planner. So shift reports are actually entered here, and it's only visible to the bed planner. Senior administration, anyone else, any of the other stakeholders do not have access to this. The bottom left-hand corner of the screen, the private room preference document collection area was added recently, which then aids the bed planner to be able to determine patients who have actually requested a private room and signed for a private room. This prevents them from having to go into each patient's account to determine whether a patient has actually requested a private room. The bed planner collects this information and enters it into a Excel spreadsheet, which was created for this purpose. Now, why an Excel spreadsheet? Why are we still sending this information up? It's important that all those persons who need to have access to this information has it at their fingertips. Now, every so often, we may not necessarily be at our desk, working from our desk. We may be in a meeting, but we still want to know what the census is, what our hospital census looks like at a specific time. You may be at home and you'd like to have that information. So the bed plan is still responsible for sending this information out 4 times daily. However, the information is captured not from calling the unit to get this information, but from just taking the information from the dashboard. This is aided in staff training. Since it's such a simple process, there are so many more staff who were able to be trained and who understand this process. The orange portions of the dashboard is information is entered and it populates the report. The calculation is done based on the formula that was created, so no one is actually calculating information. The chances of errors are much smaller at this time. The value derived from this process. The improvement resulted in increased flexibility for our staff. When we first started and before we went live with EPIC, there were 5 persons who were trained to be able to complete this report. As of now, there are 19 persons who are trained. A process that took us 45 minutes to 1 hour now takes us 4 to 5 minutes to complete. We were having ORs on hold based on the fact that the information that we were sending out was inaccurate. Now there's a 96% reduction in OR cases being placed on hold. And based on the fact that there are no ORs, there are less ORs on hold, there's less overtime being overtime hours being used, and of course there is also increased OR utilization. Our bed assignments and PACU turnover time actually speaks for itself. The average request to patient actually needing a bed, and when that bed is assigned, the times have dropped significantly. And this is actually important because patient placement within HSS is based on inpatient capacity. And patients are assigned to units based on their service. Thus, for us to be able to achieve the outcomes that we have, it was imperative that the clinical pathway adherence program was being maintained. So here I will have introduce you to David Revin, who will walk us through this process.
Thanks, Don. So, yes, I'm David Revin, Director of Within Operational Excellence here at HSS. As Don mentioned, transfer out of the PACU depends on inpatient capacity. So in this section, I'll describe how we're using our pathways to improve not only clinical care, but also how to manage our capacity. So at HSS, clinical pathways are procedure-specific post-op order sets that coordinate and standardize care. Broadly speaking, pathways standardize care by providing discrete goals and milestones for the patient, and by detailing interdisciplinary activities to deliver those milestones. We have more than 80% of our inpatients currently on one of more than 35 pathways, and we're rapidly developing our ambulatory pathways. For inpatients, once a patient is in the care of our inpatient teams, their pathway is carefully reviewed during rounds to check progression and to adjust care plans as needed to keep the patient on track. Now, when we look at our pathways, our primary performance measure is what we call pathway length of stay adherence, and I'll tell you a little bit more about that next. So at HSS, each pathway has an expected length of stay that's associated with it. And pathway length of stay adherence is when a patient discharges by their expected pathway length of stay. So you can see here there's a simple graphic that shows these two patients that are coming out of surgery. One moves to discharge before the pathway length of stay goal, the other moves to discharge afterwards. The one who discharged afterwards did not adhere, while the one who discharged before adhered. It's very simple. In this case, there's no, it's black or white. There's no gray area here, right? And that's how we look at our performance. So in 2016, our overall pathway length of stay adherence was pretty stable at about 40%. And you can see that on the chart here, which looks at performance data from February 2016 through December 2016. Now, the rate fluctuated within a few percentage points, but again, no trended improvements nor downward. Now, this is actually pretty concerning to our hospital leadership, not only for the lack of improvement, but also, just said another way, nearly only four out of every 10 patients were able to stay within their post-operative pathway. And again, that's a reflection of, it's not a reflection of lack of clinical care being applied to patients. What this is that we were not able to meet the plan that was expected for the patient. Now this matters, both in terms of clinical needs of patients, but also in terms of resource use at HSS. So if we were able to take all patients, all HSS patients, and allow them to adhere to our pathways, we would save nearly 300,000 bed hours per year, and that translates to about 35 beds. So when we are looking at our pathways and thinking about this problem, it's more than, again, just a clinical problem. It's also a resource management problem. And a way to try to look at how we can create additional inpatient capacity and therefore meet future growth opportunities and also be able to place patients, as Don mentioned in the previous section, be able to place patients on the correct service. With some clinical and administrative urgency, we decided to pull together an interdisciplinary project team. The project team was tasked with determining why pathway adherence is not improving and why patients didn't adhere in general. They were also responsible for creating solutions to achieve better adherence rates. I'll speak more to the work of this team throughout the rest of the presentation. One of the keys to highlight here is that the group was extraordinarily well represented by each of the primary services involved in maintaining a patient's progression. We had case management, nursing, PAs, physical therapy, physicians. You can see the full list here. We had great leadership support, and without that, the project would not have succeeded. Another key to success for the group is the project plan, and in this we followed a design thinking approach. We're big believers in carefully developing each project plan to meet the needs of the project at hand. And part of the project approach here rested on a deep discovery stage wherein we reviewed a tremendous amount of data to look for root causes of pathway adherence and non-adherence. During the discovery phase, the team's review of data identified several distinct groups of patients that do not adhere to pathways. You can see these groups represented on the frequency chart here, which shows volume of discharges on the y-axis and hours after the expected discharge on the x-axis. This chart is a simple visual to give you a sense of groups A, B, and C, which, when analyzed, were revealed to be functionally unique from one another. Group A includes all patients who discharge off pathway, but narrowly missed their length of stay goal. Our analysis showed that these patients were clinically indistinct from patients who stayed on pathway. They looked very healthy. What's more, the only distinguishing characteristic of these patients is that they were early surgeries. So they looked like a healthy textbook case, but they missed their pathway length of stay. And again, the only distinguishing characteristic is the hour of their surgery. Group B included patients who missed their pathway by about 12 to 24 hours. This group of patients was clinically different from Group A in that they were moderately complex. They might have a comorbidity such as diabetes, but they only had maybe one or two of these comorbidities present. Group C included patients who missed their pathway by more than a full day. The interesting thing with this group of patients is that they were significantly more complex than Group B. These are patients who would not only have diabetes, but perhaps also CHF and maybe even some sort of psychosocial need. Intriguingly, the same pattern that you see here existed for all pathways, whether or not they were a total knee, total hip, the same pattern existed. Now, these same features, hour of surgery, complexity, are the key differentiators in how a patient progressed on their pathway. So immediately the team realized that we had some level of incongruence between our pathways and the population we served. The data we just reviewed was the result of what you see here, which is simply depicted as the baseline state. First, the patient would undergo a procedure and then move to a recovery room, where a first assist would order the pathway. From there, the patient moves to an interdisciplinary inpatient care setting. And in that setting, each patient appeared to progress randomly, with some doing better than others. Ultimately, without a way to understand each patient's progression, these teams would confirm a discharge date either on the day of discharge or slightly before. And that discharge would not be specific to the patient. That is, if you were to discharge tomorrow, and tomorrow is Thursday, you get scheduled to discharge on Thursday. And Thursday, again, being a broad target, it's hard to understand exactly when that patient would be expected to leave. Like most hospitals, their discharges tended to occur between 11:30 a.m. and 4 p.m. So what would essentially result is you'd have a bunch of batch discharges on that Thursday, for example, and this unnecessarily creates discharges. Within the whole baseline experience, there were really just two underlying problems. First is that despite having multiple patient types, we had one procedure-specific pathway available for patients. More specifically, if you were a total knee patient, you received your total knee pathway. We didn't adjust our expectations by your independent characteristics. And said another way, our patients were one size fit all. There was no small, medium, or large to fit your needs. And this sets up an unrealistic expectation for clinical teams to refer our patients. Pathways are used as sequence activities at the pace that heals each patient, and without a realistic approach that is tailored to each patient, the care teams are unable to succeed. Second, the team identified that discharge date and time targets for patients were not derived from the pathway. Like most hospitals, we determine the discharge date slightly before discharge, often on the day of discharge or perhaps the night before. And this means that all the tasks needed to prepare a patient for to exit the hospital could not be aligned in advance. More fundamentally, discharges are predictable for most patients, but without having a sense of time to align activities, we were scrambling around each discharge. This lack of time-based goal determined in advance is exactly why we had Group A on the previous page, those patients who just narrowly missed the pathway target. The patient would not, or could be a morning surgery, and if their pathway was 44 hours long, we were not ready to discharge that patient in the morning 2 days later. They would discharge in the afternoon. Instead, the discharge decision would be made too close to the actual discharge time. In sum, our pathways were not built for patient differences, and there were unreliable frameworks for planning and execution of tasks. So reflecting on the baseline process, the team created a future state where pathways will have multiple levels and discharges are scheduled, allowing a team to prioritize and cascade their work. At a high level, the process proceeds as it did previously, but there are a few changes. First, immediately after surgery, the perioperative team will discuss the complexity of the case and expectations for the patient's healing time. Then, during recovery, the first assist places a specific pathway order that is no longer just procedure-based. They can select a grade from level 1 through 3, and 3 being the most complex. From there, case management and the team will give the patient a very specific discharge date and time that is rooted in the pathway itself. All pathways have been analyzed to identify an expected length of stay for each grade of patient, not just the pathway as a whole. Lastly, each patient will discharge by the exact hour planned. And again, that hour is based on the pathway and pathway level that's described after surgery. So the discharge is time-driven by a pathway order that is rooted in our data. This makes each pathway more individualized for each patient type. And by planning this way, teams can queue and organize their work in a more reliable way, and patients and families can be more prepared for discharge. This creates a shared, realistic target that we can begin to coordinate care around. Several EMR changes were required to operationalize the new process, and it starts for us with what you see here as number one on the pre-op clearance note. Prior to surgery, our patients meet with a medical doctor to review their case and clear them for surgery. During this encounter, the physician will grade the patient from level 1 through 3 as just described previously. This is critical as it informs the downstream surgical team about the medical doctor's opinion on the patient's complexity. The medical doctor is more likely to dig into some of the psychosocial needs, for example. After surgery, what you see here on point 2 is the pathway available has been expanded to cover the different graded levels of that patient. The surgeon's first assist will open the order set options, and armed with that input from the pre-op clearance note, as well as an understanding of what transpired during the operating room, they will select the pathway and level that meets the expected post-op healing process. From there, after a patient is within the inpatient unit, the case manager will document the expected discharge date and time, which is based on that order. These 3 pieces are what generates the planned discharge date and time for the patient. Once that discharge date and time and pathway are available, we now visualize the patient's course of care in as many settings as possible. The most critical of these being the electronic whiteboard, interdisciplinary plan of care, and TV in the patient's room. The whiteboard is a real-time feed from Epic that displays on the walls of each nursing unit. It shows all patients on the floor and their expected discharge date and time. The date and time are color-coordinated according to the proximity to discharge. This is what our nursing leadership can use to identify upcoming discharges. Once they know the timing of discharges, they can spread out those discharges across their staff, ensuring no one nurse is overburdened. This reduces discharge batching and the associated delays. It allows them to plan the day. Next, the interdisciplinary plan of care panel is what's reviewed during interdisciplinary rounds, which happen both in the morning and the afternoon. This provides details on the patient's progression along the pathway and helps each team member clearly understand that discharge date and time goal. And finally, the TV display is an ADT, real-time feed, that displays the expected discharge date and time directly on the patient's TV. This means that as soon as case management documents the pathway discharge date and time, or if that discharge date and time are updated, it's provided in a prominent place for the patient. This engages the patient and their family, again, in real time, helps them prepare for discharges. Now, I should say, before we move on here, visualization is key for aligning workflows. It communicates this process in a clear way and gives each person a specific view that can align their work to the goal, right? And so as long as you can display that goal in a place where it's visible in the mode of work, for example, you can begin to engage people around these shared these shared points of end for each process. In addition to the EPIC changes, we found that we needed to revisit our approach to interdisciplinary rounds themselves. This new process required a change. So out of the process, we developed a custom framework to coordinate our pathways. The framework acronym is IDOCS, which stands for Identify, Disposition, Obstacles, Change, and Share. We start each round on each patient by identifying who they are, why they are here. That's the identify. We then continue to the disposition goal, that date and time that we've been describing. From there, the team can state obstacles for why they will not achieve the goal and develop a plan to change the course of care. Or if the patient's doing really well, they can state that there are no obstacles and then challenge that disposition goal and make it more appropriate to the patient's expected healing timeline. Lastly, the team can share any changes with those who need to know. This framework was developed by the teams in rounds and speaks to their expectations for how rounds proceed. It also made the round more goal-focused rather than simply problem-focused. Our opinion, a problem does not exist without a goal. So aligning workflows to discharge date and time for each pathway went as far as looking at supporting departments and how we can better time their work to that pathway goal. An example here is our phlebotomy team, who has a work list that they use, a daily work list that they use to identify patients that they need to draw blood on. In the baseline, what we see is the phlebotomy team gathering labs at around 6 a.m. and then sending them for processing. The process is batched and would inevitably lead to delays in turnaround time. Timeliness of the results here are critical. If an AM lab comes back delayed, it may not be available by inpatient rounds, which start at 8:30 a.m. And if labs are not ready by that rounding time, a care team might delay their discharge decision until the afternoon when the next interdisciplinary round occurs. We were able to revisit this work list and reorder the patient list by the expected discharge. And to be even better at preventing the batching that was occurring, we display only those patients who have an expected discharge date and time within the next 6 hours. By doing this, again, this prioritizes lab draws for the decision-making purpose that needs to happen in the morning and improves our likelihood of meeting morning discharge dates and times, which again gets back to that group A that we described previously. The results of all these changes are now displayed on a real-time dashboard, and this is a white view of the dashboard that you can see in front of you. But some of the key measures displayed include our pathway adherence, the length of stay, discharge times, expected discharge availability on the day of surgery. So that's ensuring that teams are plotting that expected discharge date and time, again, as close to surgery as possible. And the discharge accuracy, so how well we're able to predict that expected discharge date and time. The idea here is to give each team a daily view of how they're performing. We want to get away from anecdotal explanations of change and effectiveness and start to deliver data to the hands of those who manage the process. So with that, let's take a look at what's been achieved so far. The chart on this slide shows pathway average length of stay by month from 2016 through May of 2018. Since go live in July 2017, you can see the pathway average length of stay has declined by 6.5 hours and is now nearly equal to our average expected length of stay. That's the red line there. This is about a 10% change that occurred within 4 months. The significance here, I don't think, can be overstated. By delivering the expected length of stay, we were able to better plan for use of our critical resources. We were also able to have more honest discussions with our patients with respect to setting expectations on post-operative care. Now, as you would probably expect, the change was more dramatic for our longer stay patients. This chart also displays the average length of stay, but only for those patients who are counted as our most complex. You can imagine this as group C that we'd referred to earlier. The average length of stay here is more variable due to smaller sample sizes, but we've observed a nearly 9-hour improvement since go live. What's really interesting here is that this change was more immediate than what we observed for all patients on that previous slide. The change happened within just a matter of months. To us, this means we're closing gaps in care, we're coordinating better, improving value, and particularly for our most complex patients. Speaking to our ability to better coordinate, most of the observed length of stay changes occurred within the inpatient to clear rehab phase, which is the time from when a patient enters our recovery unit to when they clear rehab therapy. This period of time is critical to measuring effectiveness in care delivery through coordination of resources. For example, if you apply PT, physical therapy, too early or too late, you can have deleterious effects on patient recovery. To that point, if you sequence your PT resources to attend to patients at just that right time, you can have gains in the effectiveness of PT. And that's part of the effect you see here, where you can see there's more of an hour change between from pre and post here for each one of the different pathways that are displayed. Likewise, as previously mentioned, we aligned our phlebotomy team to the expected discharge date and time for each pathway. As a result, we increased the rate of labs returned by morning rounds. This chart shows the % of chemistry and hematology labs returned by morning rounds for each month. We implemented our new work list in the end of January 2018, and the change here shows a net 20% boost in time when of rounds, allowing our clinical teams to keep patients on pathway. The net effect here was a 13% increase in overall pathway length of stay adherence. The change was realized over several months from July 2017 through the end of December 2017, and we've now stabilized somewhere in the mid-50s. Now, it's also interesting to highlight the 45% average in the months leading up to go live. We attribute this bump to a Hawthorne effect, where the project activity and increased attention to pathway length of stay caused teams to change behaviors and improve performance. But what you can typically see in a Hawthorne effect is regression after a few months, and you can see that regression start to materialize leading up to July 2017. Today, we're nearly 1 year into our improvements, and the gains are holding. This is a sign that our system change has been hardwired. Now, improvement in data is nice, but what the implications are in this is equally important. Greater pathway adherence has created the capacity for additional surgical cases. Increasing our net adherence by 13% leads to an improved bed capacity that ultimately equates to somewhere around 600 to 1,200 additional cases per year, depending on the surgery. As you can infer here, this change has real impact to our margins. Now, to recap, we developed a pathway management system to manage each patient's care individually. We did this by segmenting each pathway, using our data to develop appropriate discharge schedules, revisiting supporting department workflows, and queuing work by the expected discharge date and time. And lastly, measuring performance, providing data to key leaders in real time. The impacts are pretty clear. A 13% increase in length of stay adherence, a 10% improvement in average length of stay, additional capacity for surgical cases. And it's also clear that despite these changes, we still have a long way to go. We're nowhere near our goal of approximately 75% adherence. So let me tell you about some of our next steps as we go forward here. Building on our pathway segmentation work, we envision that we're moving along a timeline from the past where we had one pathway per procedure to a future where we have an unlimited number of personalized pathways per patient. This is a radical change enabled by our treasure trove of data and tighter management system with more flexible operations and rapid development cycles. We recognize the difficulty of this vision and understand that it is somewhat of a paradox to a pathway's original purpose of standardization for large patient groups. However, our hypothesis is that personalized medicine is inevitable, and we need to anchor the personalized approach in an understanding of what works for most patients with similar conditions. To that end, we're rethinking our approach to pathway development, and we're considering implementing a steering committee which will center this process. What you see here is a simple graphic of how this pathway steering committee would engage with each pathway development team to yield our desired outputs. The steering committee will provide ongoing review of performance, help prioritize changes, and establish a production schedule for pathways that will align to organization priorities. We're hoping to have this committee in place later this year. Reflecting on where we are today, I'd like to leave you with a few final lessons learned. A few of these lessons are self-stated, so I'll just elaborate on some of the more interesting ones below. First, it's important to get creative with your EMR. We tested the boundaries of what's possible with an Epic and ultimately used some very creative people within HSS to develop workarounds where needed. When it comes to management systems and systems change, a solution that you buy out of the box is unlikely to be successful and really needs some creative thought. Lastly, systems change, I don't think, can happen without clear shared goals that can be operationalized across teams. Each department needs to know how they'll contribute to the system's success and be able to measure their contribution. If you think about it, all we really did was develop appropriate patient-centered goals that each department can support. So it's easier to get behind a patient-centered goal. It still takes enormous effort to align from there. That's all we have for you today. If you'd like more information, better approach to aligning systems, feel free to reach out.
Thank you, David and Don, for that presentation. And I want to remind folks where to go find this recording and other Davies use case webinars and information on how to apply for Davies. That information can be found posted at the HIMSS Davies website, Davies Award website at hims.org/Davies. Again, that's hims.org/Davies. And thank you very much. And that concludes our presentation for today.